Dr. Alali and I will discuss a little bit about our view about clinical practice, and then we'd like to open up the remaining part of the webinar for questions from all of you about this medication, and we'd be happy to talk about its role, we think, in the overall treatment trajectory of patients, or other questions that you may have in the Q&A. So I want to start here and talk a little bit about when you think about putting somebody on this trial, is there kind of a phenotype, a general patient that you think about? I often have to remind myself that this trial has to be considered before people get too cytopenic, meaning that their platelets have to be above 50,000. What do you think about when you're sort of looking at patients overall and saying who would be the right person for me to screen for this one?
Yes, I think from my personal experience that maybe those really truly refractory patients, in the meantime, we have many JAK inhibitors and stuff like that, and we use these sequentially. And then you are left with a group of really refractory resistant patients who are really not responding to any JAK inhibitor. And this is particular, and in this group of patients, really, we have the best experiences. Patients get hopeless, and we have now also a running trial in combination. We use navtemadlin with BTK inhibitors, Vitellius, and really we do see, as I said, very dramatic responses in some of these patients. Although sometimes the management of these patients, because of the very high burden of the disease, in the beginning is not really easy. As I said, the GI symptoms, all the MF-related problems, and then treatment itself, it's not that easy, and we really need to look at them. But this is, for me personally, the ideal treatment option. We have to wait to be confirmed in the phase 3, sure.
Of course.
But this is all the personal impression I have. So I think that this is really a good niche, particularly for these very resistant patients, and particularly those also with higher blast counts. And again, we are treating, trying trials, patients with secondary AML transforming from MF with navtemadlin. So I think this is the potential. If this is, translates into improved survival, and so we have to.
Of course. So let's talk a little bit about the phase 1. What were the dose-limiting toxicities that were seen with the when it was given more frequently than, or was given for a longer period of time than just the 7 days?
Yes, it was, as I said, the GI toxicity, but also thrombocytopenia. Thrombocytopenia is very, very important issue. And as I said, a patient, even with normal platelets, could have a grade 3 or 4 drop in platelets, and relatively fast. So that's why we have to really watch these patients actually weekly at the start of treatment.
And then what do you do to prophylax against the GI toxicities? Are you giving people prophylactic anti-motility agents, anything like that?
Well, that's what we are doing for all patients, at least in the first few cycles. And sometimes some patients tell me, I didn't take it because I was waiting until, but just the feeling that these patients know about it. I think education of patients is very, very important. And, the feeling that patients are having anti-emetic treatment and that they are aware of it, it has a big impact also on the psychological effect, because we know some of the issues of nausea and vomiting is even centrally mediated. We don't give prophylactic antidiarrheal treatment, but we give them the prescription. We tell them about that to report to us. And I think with this management, many of the GI toxicities could be really mitigated, and patients can tolerate the treatment.
When we think about the mechanism of action, we saw the data that the CD34 count is going down, and that may parallel the decrease in spleen size. We know extramedullary hematopoiesis in the spleen, maybe where some of those are being released into the circulation. So it makes sense that they're going down together. I'm really interested in what it would take for you as a translational scientist to understand if disease was really being, if the clone was really being affected, if things were really reversing? Is it just the VAF level, or is there something else you'd like to see in those patients if you could do as many correlative studies as you'd like?
Well, yeah, correlative studies. The question is what I think survival, disease-free survival, and these are the really hard endpoints. Because, as I said, I even didn't show the fibrosis data because this really, even the allele burden, with all the respect, we know very well that many patients with MF, when they transform to AML, they transform from a JAK2 unmutated clone stem cell, right, and not from the JAK2 mutated cell. So for me, it's always, what is the meaning? What is the meaning of reduction in allele burden? Or what is the meaning of reduction of myelofibrosis, of fibrosis in the bone marrow? I don't know. I'm not sure. I want to see my patients surviving, and not only surviving just somehow, but with a good quality of life. And that's, I think, are the final endpoints. You could never convince me personally with an allele burden reduction. And, I don't want to remember the stories where we sit and see all these beautiful data, preclinical, and then, the drug is toxic. So it doesn't
Right.
help anybody.
Right. I do think that I think it's interesting that the correlation between the allele burden and the spleen size seems to matter. And what that says to me also is that spleen size reduction as a fast clinical measurement in a lab makes sense, because it does tell us about a little bit more about response than just the size of the spleen. It may tell us about the change in the overall number of circulating CD34 cells, which we're not necessarily seeing on the clinic in a daily basis.
Right.
One of the other things for clinical practice that's been important here, and I think this is something that's changed over the last 5 years or so, is it used to be when we only had one approved agent, for example, or one or two JAK inhibitors, that understanding, it was not as essential to understand which patients were relapsing because I didn't have a great next step. For example, if somebody's spleen grew on ruxolitinib, but they were still feeling well, there's not as much of an obligation to measure that out and really document it as well. But now that we have so many next agents, either some approved by our regulatory agencies, many in clinical trials, it's really important for clinicians to be more vigorous about documenting both the status of patients on standard of care, so that we can then know what happened in a regulated way and allow them to be eligible for those studies that come down the road.
Yes, and I always ask, why should we wait until a patient gets so refractory that nothing works? We know this from all our other hematological diseases. And I think the strategy, or we have so many trials, and I believe that something like the add-on strategy, suboptimal response, even with navtemadlin, we have a clinical trial. We use a JAK inhibitor as a backbone, wait for 3 months, see how the initial response, how the tolerability, and then put a second class of treatment. And this is what I believe might go into the future, and that this will be the future of management of most of our patients with MF, and not only waiting until they, get so refractory, get so cytopenic that, are not having a real good prognosis, and, many, many drugs could not be used anymore. So I think we should be now.
I agree 100%. I think we need to be much more vigilant earlier on about understanding who's going in the wrong direction and taking them off before they get too sick for our next studies. So we're going to open up now to the question and answer. We just have one question in the chat, but we'll start there. And I just want to continue to invite people to put their Q&As in the chat. We have a question here. When should we expect the results from the phase 3 Boreas studies to be released? Do we have any timing on that?
No, not yet, because the trial is still actively enrolling, and I think it will take some time. But I could say that the manuscript will be for the phase 2 trial, and also an overview of the phase 3 trial is in preparation and will be hopefully published soon so that one can read all these results.
That's great. Another question is sort of this from the same person who brought this up, is that how, and I'll just rephrase this a little bit, how do you talk about the, when you're talking to a patient, for example, about multiple trials, how do you couch the activity of a medicine like navtemadlin versus the other options that patients may have in second line, like pelabresib or navtemadlin? When you're thinking about that with a patient, how do you talk about this agent versus those others?
Yes, I think this is a very important issue. I always, if I have more than one option, let's say approve plus clinical trial for this particular patient, I discuss both options with this patient very open, and don't try to push my own, my own opinion or my own idea on the patient, because I always say, especially in the context of myelofibrosis, we have learned how many phase 3 clinical trials have failed for one reason or another. And I'm very open with the patients. I give them time, give experience, give data available to phase 2, and really let the patient, sure, with my advice, make the decision for him or herself, because at the end of the day, we don't know how the results of these ongoing trials will be.
Mm-hmm. Yeah, that's my approach as well. I like to also list the goals of the patient. So is your goal about feeling better? Is your goal about cure? Is your goal about not needing to come in as much for transfusions? And I try and clarify which approaches have the best data to accomplish their particular goals. I think that keeps the patient experience front and center in the decision making, and also allows you to kind of allows them to think about it in a more systematic way sometimes. So another question that came up with me is, I was very interested in whether or not this agent has, if you know of any experience with this agent, with some of the other, either an MCL1 inhibitor like a hypomethylating agent, or the BCL2 inhibitors, for example, venetoclax. Has there been any combinations that include those agents? And do we know anything about whether or not combos may synergize with the apoptotic pathways you were describing?
Yes, indeed, a very good question. Hypomethylating agents, there is a trial going on in patients with AML refractory second line treatment, where hypomethylating agents and navtemadlin are combined. We have ourselves treated a patient in this trial, but we have still to wait for the results. So indeed, and I myself love epigenetic modulation, because I think everything is epigenetics. And as I said, with an MDM2 inhibitor, I think it is a very nice and very promising combination. Let's wait and see what the results of the trials will be.
Mm-hmm, mm-hmm. Yeah, I think that especially when we're looking at that very tough group of patients, the patients with an increasing blast count, who may or may not have the absolute phenotype of AML yet, that's something where we need to pay really attention to using agents that could really increase apoptosis on all the different pathways. So patients that go into this study have to go through a screening that would clarify that their P53 status is wild type, not mutated. And maybe we could just talk for the audience a little bit about why that screening step is essential for using this drug.
Yes, I think it is a very simple explanation, because, when we inhibit MDM2, the idea is to restore a normal P53 function, tumor suppressor function. But if we have a TP53 mutated gene, I cannot restore a normal P53 function by just suppressing MDM2. And, in clinical practice, it was tried over and over again in cell lines, animal models, and even in the trials at the very beginning, to include patients with TP53 mutations, but no surprise, it didn't work.
Luckily, only about 10 to 15% of patients with myelofibrosis have a documented P53 mutation, which means that we're not going to lose out on too many patients because of that particular screening step. We do have a question here in the chat, wondering if you could update the audience on the KRT-232-114 study, which combines navtemadlin with TL895.
Yes, as I said, I just mentioned this trial. I think we're talking about refractory patients. Yes, I mentioned this trial, and I have a patient now being treated in this trial, but you know, we are still very, very early. We are still in the dose finding. So, and I don't know, I'm very excited. You know, we have the monotherapy with the BTK inhibitor, and we have this combination. We had the Boreas trials where we had the mono treatment with the MDM2 inhibition. So it is quite exciting, but you know, it's much, much too early.
Of course.
The patient is doing very fine, but you know, it's too early.
Right. I think the translation of the BTKs, the BCL2s, the MCLs, even the HDAC inhibitors, synergizing with some of these other agents is really an exciting next chapter for treatment of primary myelofibrosis. So I'm excited.